Good morning. It is my pleasure to speak about the update of the management of diabetic kidney disease. Where are we today? I'm going to discuss this topic under the following sectors and coordinates. I'll start with introduction for the management of type 2 diabetes in general. Then the targets of glycemic control in chronic kidney disease. And then I'll discuss the antihyperglycemic drugs and their use in chronic kidney disease. Few words about nutritional management, management of hypertension and proteinuria, then few statements about renal replacement therapy, and the novel targets for management of diabetic kidney disease, and I'll end with conclusion. So this is one of the important slides that I finished the pathophysiology by this slide, and I repeat it here. This is the pathophysiological defect in type 2 diabetes in general. We have 11 types of defects, and this is the existing treatment and the future treatment in phase 1 to 3 clinical trials. So one of the defects is pancreatic beta cell defects, either loss of cell mass and function of beta cell and impaired insulin secretion. The existing treatments are sulfonylureas and meglitinides. This means insulin secretagogues, and we are waiting the proved evidence for the use of imiglamine. Defect in pancreatic alpha cell through dysregulated glucagon secretion or increased glucagon concentration. The current treatments are glucagon-like peptide 1 receptor agonists, and we are waiting glucagon receptor antagonists to be proven. Diminished incretin response. The current treatments are GLP-1 receptor agonists and DB-4 inhibitors, and this is the weighted treatment, oral GLP-1 receptor agonist, once weekly DB-4 inhibitors. Immune dysregulation through inflammation. The treatment of type 2 diabetes with anti-inflammatory drugs currently available are GLP-1 receptor agonists and DB-4 inhibitors, and we are waiting the proven evidence for the use of immune modulator and anti-inflammatory agents. Increase the hepatic glucose output. The treatment currently available are Metformin and Pioglitazone, and glucagon receptor antagonists in the future. Muscle defect, so through reduced peripheral glucose uptake or insulin resistance, Metformin and Pioglitazone may work on this pathophysiological defect, and we are waiting selective PPAR modulators. Adipose tissue defect, reduced peripheral glucose uptake and insulin resistance, Metformin and Pioglitazone work on this pathophysiological defect, and future maybe selective PPAR modulators, FGF21 analogs, fatty acid receptor agonist. Defect in the kidney, increased glucose reabsorption caused by upregulation of sodium glucose cotransporter 2 inhibitors, sodium glucose cotransporter 2 receptors, and the existing class of drugs is sodium glucose cotransporter 2 inhibitors, and we are waiting in the future if combined sodium glucose cotransporter 1 and 2 inhibitors be proven to be safe and effective. For the abnormalities in brain, increased appetite and the lack of satiety, GLP-1 receptor agonists are working on this pathophysiological defects, and we are waiting GLP-1 glucagon gastric inhibitory polypeptide dual or triple agonists. Defect in stomach and or intestine through increased rate of glucose absorption. The current treatments are GLP-1 receptor agonists, DB-4 inhibitors, alpha glucosidase inhibitors, and we are waiting in the future the sodium glucose transporter 1 inhibitors. For the colon pathophysiological defects, abnormal gut microbiome and microbiota, these drugs work on this issue today, and we are waiting probiotics in the maybe in the future. Here I want to add a statement that we should encourage ladies to complete their breastfeeding because complete breastfeeding is one of the important prophylaxis, because completing breastfeeding for more than 1 year, 1.5 years, improve the gut microbiome. The abnormality, the abuse of antibiotics in early life increase the risk of adolescent obesity and diabetes. Regarding synopsis of the guidelines of American Diabetes Association, the best treatment for type 2 diabetes is metformin. Here I want to add a statement. Metformin, if not contraindicated and if tolerated, is the preferred initial pharmacological agent for the treatment of type 2 diabetes. And this is a rating based on its efficacy, safety, and its cheapness. Long-term use of metformin may be associated with biochemical vitamin B12 deficiency, and periodic measurement of vitamin B12 levels should be considered in patients treated with metformin, especially those with anemia or peripheral neuropathy B rating. So it's better to put all these aspects in our mind. So the treatment according to the American Diabetes Association guidelines, to start with, for the management of type 2 diabetes by metformin if it's tolerated and not contraindicated, and if the hemoglobin A1C is less than 9%. Because if it is above 9%, it's better to start with dual therapy. And if it is above 10% and the blood glucose level is above or equal 300 milligram per deciliter, or patient is markedly symptomatic, consider combination injectable therapy. If A1C is less than 9% and there is no, this line is not there, we start with monotherapy with metformin and with lifestyle management. Why metformin? Because the efficacy is high, hypoglycemic risk is low risk, weight change because of the use of metformin either neutral or loss of weight. Side effects are gastrointestinal and lactic acidosis. Lactic acidosis is rare if it is used within the approved indications and to be avoided in advanced chronic kidney disease. The cost is low. So because of all these characteristics, metformin is the best drug to be used if can be used. If hemoglobin A1C target not achieved after appropriate 3 months of monotherapy, proceed to drug combination. Order here in this guideline is not meant to denote any specific preference. Choice dependent on a variety of patient and disease specific factors. So if metformin is not sufficient, we can add either sulfonylurea or thiazolidine TZDs or DB-4 inhibitors or sodium glucose cotransporter 2 inhibitors or glucagon-like peptide 1 receptor agonist, or at the end basal insulin. These are the characteristics for each of them. So sulfonylurea are highly effective. The hypoglycemic risk is moderate risk. Weight gain is a side effect. Hypoglycemia is a risk, rare risk, and the cost is low. So TZDs, high efficacy, low risk of hypoglycemia. There is a risk of weight gain, edema and heart failure and the fractures. So all these are bad side effects, and the cost is low. DB-4 inhibitors, intermediate efficacy, low risk of hypoglycemia, neutral on body weight, rare side effects, and high cost. For sodium glucose cotransporter 2 inhibitors, intermediate efficacy, low risk of hypoglycemia, weight change, it encourages weight loss. Here the dehydration and infection and fracture, urinary infections, the dehydration and the fractures are side effects, and the cost is high and expensive. GLP-1 receptor agonist, high efficacy, low risk of hypoglycemia, here encouraging weight loss like sodium glucose cotransporter 2 inhibitors, gastrointestinal side effects, and the cost is high. Regarding insulin, insulin is the highest efficacy, high risk of hypoglycemia because of highest efficacy, weight gain, hypoglycemia is side effect, and the cost is high. So this is the characteristics for every component in the added treatment. So if metformin is not sufficient for management of type 2 diabetes, we can add any drug from any class, and there is no specific preference. So we select according to the patient characteristics and according to the cost of the drug. Regarding if there is no response, or if hemoglobin A1C target is not achieved after 3 months of dual therapy, so we can pass to 3 drug combination. So if we start with 2 drugs like these, 2 drugs, sulfonylurea and TZDs, we can add DB4 inhibitors or sodium glucose cotransporter 2 inhibitor or GLP-1 receptor agonist or insulin. And here, if we are starting with these 2 drugs, we can give any of these drugs to be added as a third one, and the same here and here and here. If hemoglobin A1C target not achieved after appropriate 3 months of triple therapy, and the patients on oral combination move to basal insulin or GLP-1 receptor agonist. If the patient on GLP-1 receptor agonist, add basal insulin. Or if the patient is on optimally titrated basal insulin, add GLP-1 receptor agonist or mealtime insulin. Metformin therapy should be maintained, whereas other oral agents may be discontinued on an individual basis to avoid unnecessary, complex, costly regimen. This is a very important treatment. So and at the end we may use combination of injectable therapy. So this is the steps in the guidelines and the standards of American Diabetes Association 2017. This table summarizes different classes and their glycemic durability, effect on weight gain, here no change, here decrease in the body weight, increase in body weight, and the risk of hypoglycemia either low, moderate or low, the cost high or low, and this is the key safety and tolerability issues for each of the classes. So you can fix this slide and read it in details. Before I'm going to discuss the issue of diabetic kidney disease, diabetes in general, the success for the management of diabetes depends upon application of multifactorial intervention. So lifestyle modification is very crucial and important. Use of proper antihyperglycemic drug is one of the components of the management. Treating dyslipidemia, treating hypertension, and addressing the issues of nephropathy. All we should look at the management of diabetes in a panoramic view and complementary. So multifactorial intervention, this is one of the publications regarding combined diabetes renal multifactorial intervention in patients with advanced diabetic nephropathy. If you look here, in comparison to the control, the intervention applying the multifactorial management, here you can find in the control is the darker bar. Here the presence of 3A is more with the control and less with the application of multifactorial intervention. 3B stage CKD 3B, this means SMGFR less than 45, is less with multifactorial intervention. Stage 4 is less in comparison with the control with the use of multifactorial intervention. And if we take it as a total, chronic kidney disease is lowered with applying the multifactorial intervention. So we should encourage the multifactorial intervention treatment for our patients. So regarding the glycemic control in chronic kidney disease, let us to focus on chronic kidney disease. What about our targets? In a very simple manner, in the early phases of diabetic kidney disease with normal or accepted GFR, our target is to optimize glycemic control to guard against the progression of diabetic kidney disease. But if we are treating patients with established and advanced chronic kidney disease, our principal target is to avoid hypoglycemia. So this is why the American Diabetes Association Standards of Medical Care in Diabetes 2017 recommended less stringent A1C goals, such as less than 8%, may be appropriate for patients with advanced complication, including chronic kidney disease. So if we have advanced CKD, we cannot recommend intensive blood glucose control because the risk of hypoglycemia will be a threat for even mortality. So we can start, and the KDIGO in 2012 recommended the level of A1C to be around 7%, and if the patient suffers from any hypoglycemia, to relax glycemic control to 8% or even 8.5%. Putting in our mind that hemoglobin A1C is not perfect in chronic kidney disease because some factors may lead to false high, like anemia, uremia, and renal failure, anemia, and some factors can lead to false low, like anemia management by ESA therapy. However, A1C is still very simple and easy to be used, and there are many problems with the use of alternative like glycated albumin. So we can look at A1C plus monitoring, self-monitoring of plasma blood glucose, and both of them will give a good idea about the management. The most important point, if we are dealing with advanced diabetic kidney disease, it's better to be relaxed. Hemoglobin A1C to be less than 8%, when SMGFR less than 60, due to increase the hypoglycemic risk. Reliance on self-monitoring of glucose in making treatment decisions due to imprecision of A1C, as I mentioned. And here the KDOQI in 2012, around 7%. And if there is hypoglycemia, we can allow A1C to be above 7% in individuals with comorbidities or limited life expectancy and the risk of hypoglycemia, such as those with CKD. And this is another NDT perspectives manuscript looking at consideration on glycemic control in older and or frail individuals with diabetes and advanced kidney disease. The best way is to individualize our management according to the patient's characteristics. So if we apply relaxed management for glycemic control for our patients, there are some pros and some cons. So this is the summary of pros and cons of less intensive glycemic control in frail and older diabetic patients. There is a risk of increased mortality or at least no benefit. There is no benefit regarding cardiovascular disease in 5 years. There is a 3 to 8-fold increase in hypoglycemia if we apply intensive management. There is a possible increased risk of cardiovascular events or mortality connected to hypoglycemia if we apply intensive control. Cognitive dysfunction, depression, the lack of independence could impair the effectiveness of educational programs. This benefit of a more intensive glycemic control appear after 5 to 8 years. And if the patient group has a lower life expectancy, so it's not beneficial here. Cons for less intensive management, clinical inertia may be exacerbated and lead to even higher mortality and morbidity. There is a 17% reduction in macrovascular events after 10 years. There is a benefit regarding nephropathy progression for using the intensive management. New drugs with low risk of hypoglycemia can be used. So we can look at every variable and looking at pros and cons for our strategy. Why we're afraid of intensive blood glucose control in chronic kidney disease? Because we are afraid of hypoglycemia and mortality. This is one of the outcome trials looking at 6,165 patients, and they were followed up for the median period 2.3 years of follow-up, and death was observed in 957 patients, 887 pre-indecision disease death, and indecision disease in 205 cases. So if we look here, the correlation of glycemic control with patient mortality and occurrence of indecision kidney disease and chronic kidney disease, here the safest and the green zone is between these values of A1C from 7 to 9, and less than 60% and above 9% is red zone, because there is increasing risk, either unadjusted or adjusted hazards for mortality and end-stage kidney disease. And this is the U-shaped curve. So very low levels of A1C and very high level of A1C are associated with poor outcome. And this is another study addressing the same issue of hypoglycemia. Here, the diabetic end-stage renal disease patients without hypoglycemia, this cohort, 16,000 patients, with one episode, 3,000 patients, with more than one episode of hypoglycemia, approximately 1,000 patients. And this is the hazard risks for all-cause mortality. The reference, if there is no hypoglycemia, here, if there is one episode of hypoglycemia, there is increasing the risk. And if it is more than one, is increased risk for all-cause mortality. And for subsequent severe hypoglycemia, the risk is increasing. And for myocardial infarction, there is a risk. So we, even if it's not significant, but there is a trend. So we should avoid hypoglycemia in advanced chronic kidney disease, because hypoglycemia may be fatal, and the proven effects of intensive glycemic control in well-established advanced chronic kidney disease is not evidenced. Again, this is another interesting article here. If you look here in the anti-hyperglycemic medication users, so this is estimated GFR, and this is the incident rate of hypoglycemia per 10,000 person per year. If estimated GFR above 90, so the hypoglycemia is 82 out of 10,000. But if estimated GFR is less than 15 milli per minute, or the patient is treated by dialysis, the risk increased from 82 to 700. So it seemed it increased by 10%. Tenfold increase in the risk of incident hypoglycemia. The more strange and exciting data, even if the patients are not using antihyperglycemic drugs. Here, if you compare here the patients with advanced stage 5 chronic kidney disease or patients on dialysis, here the risk of hypoglycemia is 55 per 10,000 in comparison to 2 per 10,000. So it is increased more than 20 folds rise. So even if the patient is not treated with antihyperglycemic drug, development of advanced chronic kidney disease increases the risk of hypoglycemia. So we should be cautious in the management of hyperglycemia in patients with advanced chronic kidney disease. To sum up, if we are dealing with early stages, stage 1 and 2, it's better to be strict in our management, below 7% or 7% maximum. And if we are dealing with advanced stages, we can relax our management to above 7% up to 8% or even more if the patient suffers from hyperglycemia. And it's better to combine A1C and self-monitoring of glucose. And this is just the bar system for the last slide, the 3-year of incidence rate of hypoglycemia per 10,000 persons. And here, according to GFR, you can find here, if the GFR is very low, the incident rate of hypoglycemia after the use of antihyperglycemic drugs here become very, very high, reaching up to 8 folds or more. And even for those who are not receiving antihyperglycemic drug, the risk is very manifest here in comparison to the previous stages of chronic kidney disease. What about the use of antihyperglycemic drugs in chronic kidney disease? One of the most important points is to know the drugs and their limited use by the presence of chronic kidney disease. So those modifications are very important and crucial. Regarding metformin, no dose adjustment if estimated GFR is above 45 milli per minute. Don't initiate or assess risk benefit if between 30 to 45, and discontinue if estimated GFR is than 30 milli per minute. And I'll give some data about the use of metformin and advanced chronic kidney disease, but this is the consensus and the old FDA approval. If metformin, if serum creatine exceeds 1.5 in men and 1.4 in women, it's better to avoid metformin. However, if we use metformin with advanced chronic kidney disease, we should use the lowest dose and educate the patient about the rules that I'll mention later. But this is the general recommendation. No dose adjustment if SMGFR is above 45, and discontinue if SMGFR is less than 30 ml per minute. This is regarding metformin. Regarding sulfonylurea, glipizide needs no dose adjustment. Glimepiride initiate conservatively at 1 mg per day. Glimepiride, glibenclamide avoid use in well-established chronic kidney disease. Rebaglinide initiate conservatively at half milligram with meals if SMGFR is less than 30. Initiate conservative at 60 milligram with meal if SMGFR here is above 30. This is 60 milligram for natiglinide, sorry. 60 milligram for natiglinide if SMGFR is less than 30. This is the lowest dose. And in our center, we don't have natiglinide, but we may use rebaglinide. Thiazolidine Pioglitazone needs no dose adjustment, or rosiglitazone, no dose adjustment. However, we don't like this class of drugs in well-established chronic kidney disease because they increase water retention, and this may endanger heart failure. So we don't like them in well-established chronic kidney disease. Although they need no dose adjustment, we don't give them, and we don't prefer them in patients with established chronic kidney disease. Alpha glucosidase inhibitors, avoid if SMGFR is less than 30 ml per minute. Regarding GLP-1 receptor agonist, exenatide, liraglutide, lisinatide, you can look here. Not recommended if SMGFR is less than 30. No dose adjustment recommended for the liraglutide by the manufacturer, and this no dose adjustment required if SMGFR between 60 to 90. And no dose adjustment if between 30 to 60, but patients should be monitored for adverse effects and the change in kidney function. Clinical experience is limited with SMGFR between 15 to 30 ml per minute. Patients should be monitored for any adverse effects and the change in kidney function. Regarding these drugs, LB-glutide, avoid if SMGFR is than 15. Dulaglutide, no dose adjustment for SMGFR, GFR between 15 to 90 per manufacturer. No dose adjustment recommended by manufacturer. So you can look at the corresponding DB4 inhibitors for sitagliptin, 100 if SMGFR is above 50 ml per minute. Here 50 milligram in the SMGFR between 30 to 50, and 25 milligram if SMGFR less than 30. And saxagliptin, this is a modification. Linagliptin needs a no dose adjustment, and this is for algoliptin. For amylinomimetics, pramelinitide, specific guidelines for those adjustments in CKD are not available. For sodium glucose cotransporter 2 inhibitors, canagliflozin, no dose adjustment required if SMGFR is above or equal 60 ml per minute. 100 milligram to be used in SMGFR between 45 and 59. Avoid use and discontinue in patients with SMGFR persistently less than 45. Dapagliflozin to be avoided if SMGFR less than 60. Not recommended in patients with SMGFR between 30 to 60. Contraindicated if SMGFR is less than 30. Empagliflozin, no dose adjustment if SMGFR above 45. Avoid use and discontinue in patients with persistent GFR below 45 ml per minute. And this is another table showing the modification. This is the letter T, indicated and no dose adjustment. Also show here if the SMGFR is between 60 to 90, the majority of these drugs, DB4 inhibitors, sitagliptin, vildagliptin, saxagliptin, linagliptin, allogliptin. This is the dose, and here no dose modification. For GLP-1 receptor agonist and all these, and this is their dose, no dose modification. Sodium glucose cotransporter 2 inhibitors, the major three drugs, this is the traditional dose and no modification so long as GFR, estimated GFR between 60 to 90. And then the alpha refer to modification here. In this range of SMGFR, you can find some of the drugs like vildagliptin and sitagliptin here needs no modification, and this drug saxagliptin need modification. No modification with linagliptin, and this is need modification. So if you just look at the here's the symbol, alpha means needs modification, or X needs the drug is contraindicated. So here or not to be given. Here dapagliflozin if SMGFR between less than 60 not to be given. So just to look at the symbol, T means no modification, alpha means modification, and the X means contraindicated. It's very nice. And by the same way, the American Diabetes Association, you can here follow this monograph. So starting monotherapy for management of type 2 diabetes in the presence of diabetic kidney disease, metformin dose reduction with estimated GFR between 45 to 60 ml per minute, withdraw if estimated GFR less than 45 ml per minute. And here if metformin is given and here the target is not fine, we can add another drug, and we should look at the drug that we add. We can use one of the sulfonylurea, TZDs, DB4 inhibitors, sodium glucose transporter inhibitors, GLP-1 receptor agonist, or insulin. And here it's better to look at the modification of the drugs. As I mentioned, although TZDs, pioglitazone, needs no dose adjustment, but we don't like them because of volume overload. And this is sodium glucose transporters with established chronic kidney disease. Their use is limited because of lack of efficacy, and we are afraid of side effects. And this is for liraglutide, withdrawal of SMGFR design regarding the GLP-1 receptor antagonist, exenatide, dose reduction of SMGFR less than 50 ml per minute, and this is drugs withdrawal of SMGFR less than 30 ml per minute. For insulin, there is no specific dose recommendation, but the most important point here is to monitor the pharmacodynamic effect by looking at self-glucose monitoring. If there is any hypoglycemia, we reduce the dose and monitor the patient properly. And if the target is not achieved after 3 months, we use combined therapy. And if it's not controlled, we can combine injectable like insulin with the hypoglycemia. And every minute we should look at kidney function. So we should put in our mind in the follow-up of the management, glycemic state and kidney function, because kidney function may worsen and deteriorate, that lead to limitation of some drugs not to be used. Again, for metformin, as I mentioned, if it's above 45, no contraindication, and obtain estimated GFR at least annually. Start from 30 to 45 ml per minute. Starting metformin is not recommended. Assess the benefits and risk of continuing treatment for patients currently receiving metformin. If it's less than 30 ml per minute estimated GFR, metformin use according to FDA recommendations contraindicated. Metformin should be discontinued in patients with, this is a very important point to be considered. So if even GFR allows the use of metformin, discontinue if the patient has a history of liver disease, alcoholism, or heart failure, upcoming iodinated contrast imaging procedures, because we are afraid of complications of contrast by AKI, and AKI, if develops, can increase the risk of metformin-induced or associated lactic acidosis. So here, this is may restart 48 hours after the procedure if kidney function is stable. Upcoming administration of intra-arterial iodinated contrast may restart 48 hours after procedure if kidney function stabilizes. So these are the FDA recommendations. However, this is a very interesting review discussing the could metformin be used in patients with diabetes and advanced chronic kidney disease. The answer from this review and other publication is we can use delayed release metformin in a small dose, 500 milligram, in advanced chronic kidney disease stage 4 and even 5. And we can use delayed release in a low dose and to monitor metformin level, and we can use 5 to 10 milligram per liter level, and this level will allow glucose control, and to educate the patients about sick day rules. This means if you use metformin and you feel fatigued, vomiting, etc., you stop metformin and coming for medical advice and monitoring plasma glucose. Why we are enthusiastic for the use of metformin and to use it in modified dose? Because this is one of the articles shows that metformin use is associated with lower arterial calcification scores in type 2 diabetic patients. Why? Because metformin has vascular protection. And the odds ratio of vascular calcification dropped down to 0.33. However, I'm not recommending using metformin if the patient will not be followed up properly. So kidney function, if you use even a small dose of metformin, monitoring kidney function should be followed vigilantly. So here, this is the case that is published in the current issue of the American Journal of Kidney Disease for a 75-man diabetic kidney disease, stage 3, who was treated with metformin, and metformin was used in this case in big dose. So what happened? The patient suffered of lactic acidosis. This is the characteristics, physicochemical data, and the pharmacokinetic values of metformin. This is its molecular weight. This is the most effective dose in normal kidney function, 1.5 to 3 grams per day. Absolute bioavailability from 50 to 60%. This is the percentage of the drug reaching systemic circulation from oral absorption. Volume distribution in 3 liters per kg. Protein binding here minimal. Time to peak immediate release 1 to 3 hours and extended release 6 to 8 hours. Therapeutic concentration between 1 to 3 milligram per liter. Potential lethal concentration if the level exceeds 50 milligram per liter. Plasma mean terminal elimination half-life from 1.5 to 4.9 hours. Blood mean terminal elimination half-life 17 hours. Endogenous clearance from this rate. Urine excretion 90% unchanged. Toxic dose if we exceed 100 milligram per kg in children or 5 gram in adults. However, its use in chronic kidney disease should be prohibited if we cannot monitor kidney function properly, or using the lowest possible dose from 200 to 500 milligram, 250 and 500 milligram in stage 3 and 4. But here, what happens? The patient was treated with mega dose of metformin, so the patient developed high anion gap acidosis due to lactate acidosis associated with metformin, and that necessitated slow, low efficiency extended dialysis, and this is why the metformin is released from intracellular to the blood. So we should keep an eye. If dialysis indicated, we do dialysis, prolonged dialysis, either slow continuous therapy or SLED. And here, the serum metformin level dropped to therapeutic or away from toxic level after 8 hours of dialysis. Again, we should monitor the patient because you may find some rebound in this issue. And this is how to think of a case of high anion gap lactate acidosis. Start emergency supportive measures. Non-type 2 diabetes, if it is no, calculate osmolar gap. Normal osmolar gap, drugs, search for drug like salicylate, etc. If the high osmolar gap, look at the alcohols, and then go ahead for the management properly. If the patient is type 2 diabetes and non-using of metformin, start SLED. So, and this is the management. You may need 16-hour treatment or longer with using this blood flow, 200 blood milli per minute or 300 milli per minute counter current blood flow, and the plan is 16-hour treatment or longer. So this is how we think of high anion gap acidosis with the use of metformin. Again, although metformin is the best treatment for type 2 diabetes, its use in the presence of chronic kidney disease is limited because as stated by the guidelines, if CMIT-GFR is less than 30, the drug is contraindicated and to be withheld. And if we should use minimal dose, either 500 or 250 milligram, and to monitor the patient properly or to monitor the metformin level. Regarding Pioglitazone, this is some data referring to the risk of bladder cancer in older U.S. adults with type 2 diabetes, and this study included Medicare beneficiaries aged above 65, initiating Pioglitazone 38,000 DB-4 inhibitor, 82,000 or sulfonylurea 100,000, and this was the treatment of type 2 diabetes between 2007 and 14 after at least 6 months without prescription for these drug classes. And if you look in comparison to DB-4 inhibitor, the risk is increased. Here you can, the fully adjusted hazard risk of occurrence of bladder cancer, here 1.5 in Pioglitazone in comparison to DB-4 inhibitor, 1.3 in Pioglitazone in comparison to 1 in sulfonylurea. So again, the risk is there. Regarding the issue of antihyperglycemic and nephroprotection, I suggest that you can look at this video that was published on YouTube on the last January, and it included one of the important sectors within this video is the nephroprotection of drugs. And one of the examples of nephroprotection is the use of incretin. So incretin preservation drugs like incretin mimetics and DB-4 inhibitors can have nephroprotection through cutting all these bad, and all these are devils that increase the retardation of kidney function and lead to progression of chronic kidney disease. So blocking hyperglycemia, dyslipidemia, obesity, antiproteinuria, anti-inflammatory, and reducing blood pressure, all these are targets for incretin mimetics. So all these are inhibited by incretin mimetics with subsequent renal protection. And this is the in the pipelines. This may be proven. This is an experimental study. It showed that the use of double enhancing glucagon activity by double way by DB-4 inhibitor combined with G protein coupled receptor 119. So both of them regulate glycemic control and enhance the activity, and this combination is superior to any of them. So if you look here, the islets are preserved in comparison to the vehicle or linagliptin here by using this drug HPK, which is the merge between DB-4 inhibitors and G protein coupled receptor 119. Regarding sodium glucose cotransporter 2 inhibitors, you can find this videotape 1 hour and 17 minutes that was published on YouTube 4 days ago, and this is one of the slides. This is the scenario in a normal person. You can find everything is fine. Absorption of sodium is normal, and so some sodium reached the macula densa. All glucose is absorbed in the proximal convoluted tubule, 90% in the early segment by sodium glucose cotransporter 2, and 10% in the late segment of proximal convoluted tubule through sodium glucose cotransporter 1. And so long as sodium is reaching macula densa in a normal concentration, everything is fine. You can find the afferent and efferent arteriole. Afferent is a little bit dilated than efferent, but everything is a normal tone, and the tubular glomerular feedback is perfect because sodium here is normal, so everything is fine. But in type 2 diabetes, what happens? The expression of sodium glucose transporter 2 is enhanced within proximal convoluted tubule. Subsequently, the glucose absorption is increased with concomitant increase in sodium reabsorption by proximal convoluted tubule. This is why the threshold of glucosuria increase with the price of hyperglycemia. So the sodium reaching macula densa will be reduced, and this will impair and decrease tubular glomerular feedback. Decreasing tubular glomerular feedback with concomitant increase of angiotensin 2 will lead to afferent vasodilatation and efferent vasospasm. the presence of this cocktail will lead to increasing hydrostatic pressure, leading to hyperfiltration. This is the same in normal scenarios. Sodium glucose transporter is expressed like this circle, and as you see, the circles are increased in type 2 diabetes, and the only way to normalize the abnormalities to use sodium glucose transporter 2 inhibitor. It will will lead to glucoretic and natriuretic, and neutralizes the tuberculin feedback. The most important statements according to US and European guidelines is to assess renal function prior to initiating sodium glucose transporter 2 inhibitor treatment, because in canagliflozin, dose adjustment and more frequent renal function monitoring are recommended in patients with SMGFR less than 60. Limit dose in the SMGFR between 45 to 60 to 100 milligram. Cana shouldn't be given and initiated for patient with SMGFR less than 45 milli per minute, and is not recommended when SMGFR is less than 45 milli per minute. Sodium glucose transporter inhibitors are contraindicated in patients with severe renal impairment, SMGFR less than 30 milli per minute, or patients are treated by dialysis. For dapagliflozin, assessing renal function, no dose adjustment if estimated GFR is above or equal 60 milli per minute. DABA should be not be initiated if estimated GFR less than 60. DABA is not recommended in patients with estimated GFR between 30 and 60. And the empagliflozin, no dose adjustment is needed if estimated GFR is above 45, and EMBA shouldn't be initiated with estimated GFR 45. Discontinue if estimated GFR dropped below 45. This is the recommendation within the United States, and within European recommendation, assess renal function prior to initiating sodium glucose transporter 2 inhibitor treatment, and at least annually thereafter, prior to initiating concomitant medications that may reduce renal function, and periodically thereafter, at least 2 to 4 times per year for renal function approaching moderate renal impairment. So we should put all these points in our mind when we are treating patients and thinking of use of sodium glucose transporter 2 inhibitors in the presence of chronic kidney disease. And within the presentation of sodium glucose transporter, you will find this slide which reflects the ethics of using this class. Yes, this class, if properly used with preserved kidney function, may have nephroprotective effect, and it's beneficial and even can benefit blood pressure, body weight, etc. However, the use is prohibited in moderate to severe CKD, stage 3B. This means estimated GFR less than 45 milli per minute. Pregnant and breastfed women, because breastfeeding women, because the risk is not known. For the treatment of diabetic ketoacidosis in acute stressful and catabolic stress, because we are afraid of lactic acidosis. Observe caution in the use of sodium glucose transporter 2 inhibitor therapy in the risk of volume depletion. Frail elderly should be cautious. Concomitant use of loop diuretics, condition predisposing to dehydration or renal impairment. So it's better not to give diuretic plus sodium glucose transporter in the same moment, inhibitor in the same moment. We can start one by one and monitor kidney function before any and after the starting of any management or increasing the dose of diuretics or ACE inhibitor, etc. In combination with diuretics, monitor fluid and electrolyte status, insulin and sulfonylurea. Down titrate the dose of insulin and sulfonylurea to minimize hypoglycemia, because yes, hypoglycemic risk is low with this class if it is given monotherapy, but if it is added to potent drugs, it's better to down titrate the dose of potent drugs like sulfonylurea and insulin. In the presence of complicated UTI, it's better to not to be given and to be temporarily discontinued. History of recurrent UTI or anatomical obstruction to urinary tract, the risk of UTI may increase. Condition of fasting, the risk of starvation and precipitation of euglycemic DKA. Patients who already elevated hematocrit because we are afraid of thrombosis, etc. And you can find the rest of the slide within the presentation of sodium glucose cotransporter 2 inhibitors. In the presentation, you'll find the side effects, euglycemic ketoacidosis, how to predict, and the most important risk factors for prediction is the very low level of C-peptide, especially if the patient is treated with diuretics and statin. So please look at the video to find all details about sodium glucose cotransporter 2 inhibitors. Few words about the nutrition. The nutrition treatment is very crucial in management of chronic kidney disease, and it's very special in the management of diabetic kidney disease. All these are the diet currently considered useful in managing diabetic patients. However, my recommendation is we should deal with nutrition as the specialty, and the role of nutrition is of paramount important. And yes, we may need to cut down calories, but we should avoid at all wasting muscle, because muscle wasting means increasing comorbidity. And this is one of the studies. We should avoid sarcopenia. Sarcopenia means decreased lean tissue index in patients with chronic kidney disease. And lean tissue index can be diagnosed by multi-frequency bioimpedance spectroscopy device, or at least monitoring the patient's status, mid-arm circumference and muscle. So any diet regime, we should depend upon the collaboration with dietitian. And the lean tissue index of less than 10% of the normal value indicates muscle wasting. Regarding the obesity and the kidney, obesity is bad, and we should guard against obesity and encourage the weight control. And this is a very nice article discussing the issue of gut-brain axis that is stimulated by gastric bypass surgery, and it opened the way and paved the horizon for development of oral drugs that stimulate this axis that may control satiety. Regarding hypertension, this is a very interesting article that was published in the last May about hypertension in diabetes, and this is a sector of hypertension adults in general, and this is a sector of diabetes. So here I stress on home blood pressure monitoring in diabetes, because home blood pressure is important to tackle the blood pressure. So home blood pressure in diabetes and in chronic kidney disease. And this is the initial treatment, S inhibitor or ARBs, especially if there is proteinuria, albuminuria. Combination of dihydropyridine, calcium channel blocker, is preferred over thiazide or thiazide-like diuretics. A loop diuretic could be avoided in hypertensive chronic kidney disease patients with extracellular fluid volume overload. Here, a loop diuretic could be considered in these patients with hypertension and with extracellular fluid overload. In hypertension without chronic kidney disease, we may depend upon thiazide, but with patients with established chronic kidney disease, loop diuretics may be the recommended. Persons with diabetes mellitus should be treated to attain systolic in the range of less than 130 and diastolic less than 80. And regarding intensive blood pressure control, here the conclusion in diabetes is inconclusive evidence. We don't recommend intensive blood pressure control in diabetic patients. What's meant by intensive blood pressure is to reduce systolic blood pressure to less than 120 millimeter mercury, because patients who can benefit from intensive blood pressure control to a systole less than 120 are those patients. But in diabetes, the evidence is not conclusive. Regarding the issue of RAAS blockade in stage CKD, stage 3 to 5, this means estimated GFR in stage 3 between 60 to 30, and stage 4 from 30 to 15, and stage 5 less than 15, and the patient is not dialyzed yet. You can, if you look here, in comparison to placebo, there is no significant difference in all-cause mortality and in cardiovascular mortality. But you can find here a favor of the use of RAAS blockade for the decreasing the need for renal replacement therapy, occurrence of end-stage kidney disease, or doubling of serum creatinine. So there is some beneficial effects on the kidney. However, there is no improvement in patients' mortality. Regarding the mineralocorticoid receptor antagonists, there is evolution according to this very nice and very recently published review. And as you see, these are the mineralocorticoid receptor antagonists, spironolactone. This is the study and the outcome, and you can look here. The hyperkalemia risk is there, and the potency is okay. So spironolactone and anti-aldosterone and eplerenone. This is the hyperkalemia risk is high. And regarding finerenone, which is non-steroidal mineralocorticoid receptor antagonist, a lot of accumulating data are promising. So mineralocorticoid receptor antagonists are highly efficacious for further reducing albuminuria when added to SGLT inhibitors or ARBs in diabetic kidney disease. However, the major risk is worsening hyperkalemia. Novel non-steroidal mineralocorticoid receptor antagonists are currently being developed to overcome such limitations. Non-steroidal finerenone has different physical, chemical, and tissue distribution properties compared with steroidal eplerenone or spironolactone. Finerenone has, for less hyperkalemia, has had promising results and is currently being tested in further renal and cardiovascular outcome trials to examine effects on outcomes. Phase 3 trial will have to show whether finerenone might become the third generation mineralocorticoid receptor antagonist for the treatment of heart failure and diabetic kidney disease. This is a study, phase 2B, double-blind randomized control trial, including 96 patients using seven once daily oral doses of finerenone, starting from 1.25 up to 20 milligram versus placebo. And you can look at the side effects. The risk of hyperkalemia is minimal. And this is the change in serum potassium. You can here look at the different dosages of finerenone in comparison to placebo. So, and this is the change in GFR. So it seems that this drug is potential. Regarding amiloride, in one of the previous presentations, I mentioned in diabetic nephropathy, there is a problem in secreting plasmin with proteinuria, and the plasmin will activate sodium channel. And the concept of proteinuria-induced hypertension, according to initial data, stimulated the idea of using amiloride, a sodium channel blocker in the distal nephron, to block the activity of plasmin and to be used for treating proteinuria-induced hypertension. However, this trial of amiloride in type 2 diabetic patients with proteinuria was experienced with side effects like hyperkalemia and acute kidney injury that was prematurely terminated. So it seems that amiloride is not superior to thiazide, but the idea of plasmin needs further evaluation. Regarding renal replacement therapy, you can find these presentations on YouTube, including one of important sectors within the presentation of guidelines for diabetic kidney disease, including the renal replacement therapy, how to prepare patient for dialysis and transplantation, and diabetes and kidney transplantation, and the post-transplant diabetes and the post-donation diabetes mellitus. All these are presentations targeting the issue of replacement therapy. However, the best replacement therapy is according to the availability. So renal transplantation is superior to dialysis, and the type of transplantation, according to type 2 diabetes, there is no role of pancreas transplantation. In type 1, yes, if the kidney and the pancreas is available, and if the patient comorbidity is low and the patient is fit, we can proceed for combined kidney and pancreas. But if the patient has a living kidney donor, we can start with a living kidney donor living kidney transplantation, and to put the patient on the pancreatic list, transplantation list, if he is fit, because transplantation pancreas needs more fit persons. Regarding A1C and the outcome in dialysis patient, this is a unique hemoglobin A1C level distribution and its relationship with mortality in diabetic hemodialysis patients in Japan. So this is J DOPS, and you can look at the number of patients for each phase for each year and the percentage of A1C less than 5%, from 5 to 6, 6 to 7, 7 to 8, or above 8%. And this is again the number of patients for each category of hemoglobin A1C. Look here, if hemoglobin A1C is less than 5% or above 8% in dialysis patients in Japan, either using the unadjusted or adjusted hazards here, unadjusted hazards or adjusted hazards are higher with very low and very high values of hemoglobin A1C. This is another interesting report regarding the pre-transplant hemoglobin A1C and the occurrence of post-transplant diabetes. It seemed that the A1C above 5.4 is the risk for post-transplant diabetes in this study. Regarding the use of glucose-lowering drugs in a patient who developed new onset diabetes or post-transplant diabetes, it's better to look at kidney function, because we can consider kidney transplant recipient as a special state of CKDT, chronic kidney disease. So we should monitor kidney function, because you may find limitations for the use of some antihyperglycemic drugs. So first generation sulfonylurea are completely contraindicated and avoided because of limitation of their use and for their drug-drug interactions with immune suppressive drugs. Second generation sulfonylurea, glipizide and gliclazide, no modification except if there is very high serum creatinine, and there may be interaction with immune suppression as cyclosporin. You can look here and you can look at the avoid or dose adjustment according to the drug. Metformin to be avoided if SMGFR is if low, the same for these drugs. And here the TZDs avoid in heart failure, incretin mimetics, and there is the recommendation regarding the sitagliptin, vildagliptin, and saxagliptin. This is the scenarios, and this is the interactions with the immune suppressive drugs. Regarding novel targets are discussed within the most important issue here is to look at the lecture of pathophysiology, and if we can ameliorate or reverse pathophysiological defects, this may be the new target or novel targets if proven in further studies. So this is one of the ideas, is approaches towards the development of chimeric. Chimeric means mixture, or a structure that include DB4 inhibitor and the angiotensin converting enzyme inhibitors for treating metabolic syndrome. So we are waiting. This is another article with the same title, New Insights into Established Therapeutic Paradigms and Novel Molecular Targets, looking at anti-inflammatory, COX, and then oxidase inhibitors, monocyte chemoattractant protein 1 inhibitors, tumor necrosis factors, alpha inhibitors, nuclear factor kappa beta, signaling a role of protein kinase C, and other pathways in the management of diabetes. And this is another study shows, if you look at the color code, this color code reflects current treatment like S inhibitor ARBs here, this color reflects emerging treatment in ongoing clinical trials, and this color refers to emerging treatment. You can fix this slide looking at the color code. So the DB4 inhibitors are there, sodium glucose transporter 2 inhibitors are there to here to monitor, to control blood glucose and the blood pressure. However, selective NOx, NADPH oxidase, and I'll mention this pathway in other slides, inhibitors, NADPH oxidase 1 and 4 inhibitors, PKC inhibitor, age and advanced glycation in the products inhibitors, are all these are emerging, needs all these axes need to be proven, and other axes need to be proven too. So please fix this slide. Look at the color code. And as I mentioned, it's better to look at the pathophysiology presentation to know the different aspects. One of the slides from the pathophysiology is adiponectin, and it seems that adiponectin receptor agonist may have a role in the future, because in chronic kidney disease there is the problem in the there is adiponectin resistance. So if we can have adiponectin receptor agonists, this may help. Beta-2 adrenergic receptor that increase B-arrestin and lead to inhibition of kappa beta, and stabilizing inhibitor of kappa beta may have a role, and linking inflammation with neurological management in type 2 diabetes to avoid vascular complication, and dual therapy targeting the endocannabinoid system prevents experimental diabetic nephropathy. So combining therapy with AM6545, a peripherally restricted cannabinoid receptor type 1 neutral antagonist, so it is antagonist, and this AM1241, a cannabinoid receptor type 2 agonist. So antagonist and agonist combined together, this is dual therapy targeting endocannabinoid system may be of value. Combination of coenzyme Q to target the pathophysiology and oxidative stress, and the problem is the coenzyme Q may not be stable and in the environment, so it needs to be loaded. So loaded liposome with ultrasound targeted micro bubbles for early theranostics of diabetic nephropathy. It may be in the future. Regarding NADP oxidase, so NOx inhibitors, the combined NOx 1 and 4 inhibitors may be of value in renal and arterial protection in microvascular and macrovascular diabetes. Another study showing the NADP oxidase 4, NOx 4 inhibitors in diabetes, and the work pioneered and the pioneer work run by and moderated by Professor Ghanem at Urology and Referral Center with his fascinating team, Professor Ayman Rifai and Dr. Mahmoud Gabr, Professor Ayman Rifai and Dr. Mahmoud Gabr, and this is Sir Roy Khan. Professor Ghanem started his journey with mesenchymal stem cell and with stem cell in the management of diabetes in rats, and then in dogs, and I think in near future we may have applications in clinical trials. So we are waiting the evolution of the stem cell in Urology and Referral Center in the future. And in the MD nephrology thesis of Dr. Summer, we are working on diabetic rat model, and we are testing how to manipulate the autophagy system for the sake of control of diabetic kidney disease. So we are waiting the result of Dr. Summer. To conclude this presentation, we need advancement, so we are waiting further research in medicine, because currently we depend on creatinine, GFR, proteinuria. So this is the clinical decision making in the current era, but in the future we may have complicated issues from genotyping and proteomics, and if we know the patient's characteristic, this will be the precision medicine to targeting the best treatment for a specific person according to his needs, and this is a proteomics map. And again, as I started this presentation with a stress on the multifactorial intervention trial, it seemed that the secret of success of management of diabetes nowadays is in the multifactorial intervention trial, until we have magic bullets for the management of diabetic kidney disease. So, multifactorial intervention trial decreased the incidence of end-stage kidney disease in American Indians with diabetes. Is a model for other high risk. Is it a model for other high risk population? Although we don't have evidence-based medicine in this issue, but it seems that there are accumulation cumulative data toward the superiority and advantage of multifactorial treatment. So again, This is the always my finishing slide. The statement and quotation of William Osler, the father of medicine. He who studies medicine without books sails an uncharted sea, but he who studies medicine without patient doesn't go to sea at all. This means we should keep eye on learning, reading, and updating ourselves in the same moment, treating patients and building our experience. And by this, at this point, this is the end of the management update, and the management update will be added to the YouTube to all the previous series of diabetic kidney disease pathophysiology, sodium glucose cotransporter 2 inhibitors, diabetes and post-transplant diabetes, and post-donation diabetes, the diabetes update in April and in January, and the crossword within the diabetic kidney disease within the current issue of Journal of Egyptian Society of Nephrology and Transplantation. At this point, thank you very much, and I hope that you find some benefits and some values of these presentations. And please, if you have any question, don't hesitate to send your question to my email. Goodbye, and thank you very much.